All right, let's just jump right in. Welcome to this rapid-fire explainer designed specifically for you, our radiation oncology residents in training. Whether you're actively prepping for the boards or just really looking to lock down your clinical foundation, you're absolutely in the right place. Today, we're going to take some seriously dense, board-heavy data and distill it into structured, high-yield takeaways. We'll be relying on the visuals to build up your mental framework, focusing on those absolutely critical pediatric syndromes and the essential must-know details of Ewing sarcoma. So here's our game plan for today. We'll hit high-yield pediatric syndromes, Ewing sarcoma epidemiology, survival rates by presentation, key genetic rearrangements, and finally, treatment and local therapy. Let's get to it. Starting off with Section 1, high-yield pediatric syndromes. Now, let's create a mental snapshot of these classic presentations right alongside their distinct chromosomal disruptions. As a RadOnc resident, you need to be able to tell these apart literally in your sleep. Check out those first two rows, Denise, Drosh, and Wog. Both are intimately tied to the WT1 gene on chromosome 11, and both present with Wilms tumor. But look closely at the clinical differences. Denise Drosh presents with pseudohermaphrodism, where the external genitalia just don't align with the genetic sex, and mesangial renal sclerosis. And crucially, it's driven by a WT1 mutation. Compare that to Wogger syndrome, which is driven by a WT1 deletion. Wogger is your classic acronym, right? Wilms tumor, aniridia, genital urinary anomalies, and mental retardation. Then, dropping down to the bottom, we have Beckwith-Wiedemann syndrome. This one brilliantly illustrates a totally different genetic mechanism. We aren't looking at WT1 here. Instead, we're looking at errors in chromosome 11p15. That error leads to an overactive IGF2 gene and loss of CDKN1C, which, if you recall, is a cell cycle inhibitor. The clinical picture, distinctly different. You'll see macroglossia, macrosomia, midline abdominal wall defects, those specific ear creases or pits, neonatal hypoglycemia, and hemihypertrophy. Definitely lock this table into your memory. Now, before we transition into our main focus and really start peeling back the complex, layered biology of Ewing sarcoma, kind of like the layers of an onion you're seeing here, let's do a quick reset. We're shifting gears from congenital syndromes to an incredibly aggressive pediatric malignancy where your role in local control is, well, it's absolutely paramount. Moving right along to Section 2, Ewing sarcoma epidemiology. For the boards, and honestly for your clinical practice too, you've got to firmly associate Ewing sarcoma with a highly specific demographic profile. Remember, this is the second most common pediatric bone cancer, right behind osteosarcoma. But it's still relatively rare, with an incidence of only about 200 cases a year in the US. The typical age of presentation is a pretty tight window, usually 10 to 14 years old. You'll see a slight male predominance and, really importantly, a strong predilection for Caucasians. So, when you get that clinical vignette of a 12-year-old Caucasian male with a bone lesion, Ewing should instantly jump right to the top of your differential. So where does this tumor actually like to show up? Well, the appendicular skeleton completely dominates at 75%. Breaking that down a bit more, the lower extremity accounts for 65% of cases, specifically the femur at 30% and the tibia at 10%. But look super closely at the pelvis, sitting right there at 20%. Here's the absolute crucial takeaway. Always pay special attention to the pelvis because pelvic disease carries a notably higher metastatic risk compared to the other primary sites. The remaining 25% of cases, those present in the axial skeleton, like the chest wall, spine, and skull. All right, up next is Section 3, survival rates by presentation. This is the hard data you're going to need to quote to your patients and their families. Notice that massive, steep drop-off in 5-year overall survival based on how the disease presents. If your patient has localized disease, that 5-year overall survival sits around 70%. If they present with an isolated pulmonary metastasis, that number takes a hit, dropping to about 50%. But look over at the far right. If the patient is metastatic at presentation, meaning gross metastases in the lungs, bone, or bone marrow, the 5-year overall survival just plummets to less than 30%. And unfortunately, about 20 to 25% of patients will present with these gross metastases right out of the gate. So how exactly does this dictate our treatment philosophy? Well, even though 75 to 80% of patients present with seemingly localized disease on their imaging, you have to remember the central dogma. Subclinical micrometastases are likely present in nearly all patients. This fact is exactly why localized therapy alone, like surgery or radiation, is simply never enough. Systemic chemotherapy is an absolute requirement for every single patient. It acts as the vital backbone of our management to hunt down all those invisible micrometastases. Let's dive into Section 4, key genetic rearrangements. While histology definitely gives us some essential clues, it's really the molecular biology that locks in the diagnosis. Remember that utilizing FISH, fluorescence in situ hybridization, is the definitive, absolute gold standard for a Ewing's diagnosis. And what are we actually looking for with FISH? We're hunting for the EWS FLI1 fusion protein. Biologically speaking, you need to know that this fusion protein acts as an aberrant transcription factor. It specifically drives the EWS promoter to just continuously fuel that tumor growth. Now, board examiners absolutely love to test if you can distinguish Ewing's genetics from other classic translocations. So you got to lock this specific table into your memory. You want to cleanly differentiate the T1122 translocation of Ewing's sarcoma, which remember creates that EWS FLI1 fusion we just talked about, from the other famous translocations. For instance, T922 gives you the BCR ABL fusion. That's your classic Philadelphia chromosome driving chronic myelogenous leukemia, or CML. And please don't confuse it with T213, which creates the PAX3 FX01 or PAX3 FKHR oncogenic fusion that drives the biology of alveolar rhabdomyosarcoma. Knowing the specific numbers, 1122 for Ewing's, is completely non-negotiable for the exam. Which brings us to our final section, Section 5, Treatment and Local Therapy. Because we're assuming micrometastatic disease is already present, the treatment timeline is honestly a marathon. Take a look at Step 1. We always start with induction chemotherapy for weeks 1 through 12. This relies heavily on the VAC-I regimen. That's vincristine, adriamycin, or doxorubicin, and cyclophosphamide alternating with isophosphamide and etoposide. Then look at Step 2, week 12. This is your time to shine. Notice how local therapy is carefully wedged exactly at week 12. This could be surgery, radiation therapy, or a combo of both. And here is a massive, real-world clinical pearl for your practice. Never, ever forget to hold adriamycin and sometimes actinomycin D during radiation therapy. Why? Because of severe compounding toxicities. Finally, Step 3. After local control is achieved, patients undergo adjuvant chemotherapy for up to 48 weeks. It is a really grueling year-long process for these kids. So when definitive local control falls entirely to radiation therapy, meaning surgery just isn't an option because of the tumor's location or the potential morbidity, what dose are you prescribing? 55.8 gray. That's it. 55.8 gray is the highly specific, single institution target dose you absolutely must commit to memory for achieving local control in Ewing sarcoma. It's a number that's going to follow you throughout your entire residency and well into your attending years. And that pretty much brings us right to the edge of what we currently know. As you continue your residency training, I really want you to consider this question on our final slide. If subclinical micrometastases dictate our entire systemic approach, how might advancing systemic agents, maybe ones targeting the EWS-FLI1 transcription factor directly, eventually challenge and reshape our reliance on 55.8G for local control? I mean, will week 12 always be the magic window? It's something to think about. Keep learning, keep questioning the paradigms, and use these visual structures to really anchor your clinical knowledge. Thank you so much for joining me on this explainer, and I'll patch you in the next one.